Everyone. Uh, so today we're going to be talking about porcelain laminate veneers. In this lecture, we'll be talking about indications and contraindications for veneers and methods of preparation and shade selection, provisionalization, cementation, and of course the prognosis and long-term results for porcelain laminate veneers as a treatment method. First of all, if we're talking about the introduction, we need to understand that veneers is a thin layer of porcelain which covers the facial surface of the tooth, and it's considered as a conservative alternative option for full coverage uh, of a tooth. And in order for that, we need to improve the appearance of any anterior tooth using this treatment methodology. Some of the indications is stained or darkened teeth, hypocalcification, multiple diastemas, in case of peg laterals, chipped teeth, or lingual positioned teeth, malpositioned teeth that require uh, that do not require orthodontic treatment. And the contraindications, we need to take into consideration that some of these contraindications is insufficient tooth substrate, or there is not enough enamel. We'll be talking about the importance of enamel for bonding of porcelain laminate veneers later in the lecture. The labial version, which is the movement of the excessive movement of the anterior teeth labially or facially, which requires excessive reduction, which is in this case considered as a contraindication, as it requires removing a lot of enamel. Also, in cases of poor oral hygiene, and if there is any parafunctional habits like bruxism, for instance, and if there's moderate to severe malpositioning or crowding of teeth, which might be a good indication for orthodontics. So, in terms of facial or in terms of veneer preparation, um, we need to take into consideration that there are multiple uh, uh, positions for preparation. First of all, we'll start by the axial position, and we have to understand that there are specific designs on how to actually do the reduction in the axial design and in the incisal area as well, the interproximal area, and the gingival margin design. We'll start by the actual design. So we have to understand that the key for success is to have enough enamel around the facial surface once we're done with the preparation. In other words, we're trying to be as preservative or conservative as possible. We can see that regardless of the amount of reduction that happened, we'll still have enough enamel because enamel is very important for the cementation success of veneers and the long-term success for these veneers to remain in the patient's mouth. With the use of the silicone preparation guide, we'll be able to use these guides to tell us exactly how much reduction we have done. And these guides are actually made on top of diagnostic wax up, as you can see. A lot of the cases requires diagnostic wax up because after the wax up, we'll be able to know exactly how the shape would look like um, before we even do any preparation. Another way of doing these guys is to use a vacuum shell, as you can see, and the depth of preparation can be marked here and as by using the periodontal probe. When we talk about the incisal reduction, we have to understand that the ideal form of reduction in the incisal part is to use the butt joint, which is a flat surface, not a chamfer, because it has been shown that the butt joint finish line had showed very superior support for the veneers, and that would actually give enough support for the veneers uh, uh, that would resist any kind of fractures. Another way of actually looking at the amount of reduction that is done incisally is to use the palatal incisal reduction stent or index. As you can see, the wax up that has been done on the cast, when we transfer this index to the patient's mouth, we see that there are some spaces here, which tells you that this is how we want the teeth look after we do the final veneers based on the diagnostic wax up. And from this, we know that we don't need to reduce a lot of the incisal edge. We usually reduce about 1 to 2 millimeters. And we can see that in cases like this, we're doing only 1 millimeter reduction because the rest of the 1 millimeter is actually coming from the diagnostic wax up. So by doing it this way, we're actually reducing the amount of reduction that is happening on the tooth structure, which is considered a conservative method of preparation. In terms of the intraproximal design, we have to take into consideration that there's multiple ideas about that, and we can see that if we follow the approach of having maximum enamel preservation, we'll try to reduce only enough uh, to open the intraproximal area, but it's not really indicated to open interproximal areas unless there's three instances. If there is a diastema, like in this case, as you can see it here, we have to open the intraproximal areas because we need the porcelain laminate veneer to go as palatally as possible to aid in closing the intraproximal area efficiently with the veneers. But if there is no diastema, we don't need to go beyond the interproximal contact area, which is around here. Just going at the contact area without opening it would be enough. Well, usually we need to have some sort of space here, very thin space, so at least the impression material will be able to pick up this area. Also, if there is existing interproximal restorations, we have to go beyond the restorations on sound tooth structure in order to maximize the bonding strength of the veneers. And if we want to do significant color change, because if the teeth are heavily stained, usually we need to do a lot of preparation still within enamel in order to have enough thickness of the veneers. And usually by doing so, we have to go back posterior as much as possible in order to actually give enough thickness for the veneer to be able to control, to change the color of the tooth. In terms of the gingival margin, we all know that there is a very thin layer at the incisal part of the facial surface of the anterior teeth, and usually you need to be very careful not to have excessive preparation in order to remove a lot of the enamel and going all the way to the dentin. So the recommended amount of reduction depth is about 0.3 to 0.5 millimeter at that area, but we have to take into consideration that there has to be a clear margin so the technician will be able to know where to end the veneer and where does the sound tooth structure starts after that. This is important for a lot of reasons. One of them is to make sure that there is enough clear uh, uh, light transmitted from the veneer to the natural tooth structure. And in order to do that, we have to have it somewhere underneath the gingival surface. And another reason is to not to have any kind of spaces in here, which would cause, or also overhangs, which will cause um, food entrapment, and then later will cause any kind of gingival inflammation. In terms of shade selection, you have to take into consideration that this is a process that is carried both by the patient and the dentist mutually, which means that they need to agree on the final shade of the case before even the preparation is started. And the reason for that is that we need to make sure that we have to meet the patient expectations, but we also have to moderate the patient expectations in order to put him in the reality realm. Because if the patient have higher expectations, if he wants super white teeth, while we know that the teeth are actually are heavily stained, this might complicate things. So in order to get to that result, we have to agree upon or have to understand that the final color will be affected by the tooth surface color. If the tooth is heavily stained, the final color will of the veneers will be affected. If it's dark, the veneers are translucent most of the time, depending on the type of material used for that. But the majority of them actually show through uh, the underneath layer or the shade of the underneath teeth. We have to understand the more ceramic layer thickness, the more we can control the color. But don't forget that more thickness for the ceramic might indicate that we need to do a lot of preparation for the tooth, which is not conservative, and this might also result in reduced uh, uh, cementation strength because there is not enough remaining enamel on the tooth structure. Also, the type of cement color will have an effect or an impact on the final shade of the veneer and the veneer fabrication technique, which we'll be talking about later in this lecture. We have to understand that the tooth itself has a shade, and we call that the natural dye shade selection. And there is a specific type of shade guide for the natural dye material. We call it the ND shade. In other words, we can use stump shade as well, and that's a similar terminology. Um, and why is it important to actually have the shade selected for the teeth? Because if the teeth are very dark, we have to understand that the final results is affected by two things: the cementation material and the color or the final shade of the veneer itself. And there's techniques actually that can be done in order to uh, uh, make sure that the final color of the veneers is done properly. So before we use the final resin cement of the or the final cement paste for the veneers, there is try-on paste that has a similar or different color patterns. And you can see it start by moving from warm all the way to light by neutral or translucent here in the middle. And by this, we have the ability to try in the veneers with multiple underlining veneers, veneer cement shades, in order to make sure that we got the right color. When we start the process of the provisionalization, in order to do that, we need to do a diagnostic wax up with multiple index, as you can see. And then we start the preparation on the patient mouth, and we use these indexes to do the provisionalization using bisque acrylic um, uh, temporary resin. And in terms of the methods of laboratory fabrication, we have the press technique, and usually we have the ingot of the porcelain in this shape. This comes in multiple colors, translucencies, and shades as well. And by that, we start by doing a wax up for the veneers. These wax ups are actually attached to the sprue here and then invested. There's a plunger that actually pushes the heated uh, ceramic ingot all the way inside the investment, okay? Just like the regular lost wax technique from the metal fused to ceramic crowns. And this is usually the furnace. So after the heating process for the ingot is completed, then a plunger will push this um, uh, uh, ingots, heated ingots, melted ingots inside the vestibule or crucible, as you can see here. This is how it looks after it's been um, the investment has been opened up, and then um, the process for cleaning these veneer shells, and then additional layers using the cutback technique to put the other uh, accessory shades on the incisal edges, like the hollow effect or the mammalian effect, or any other form of internal characterization of the color before actually delivered to the clinic. The other technique is to use the layering technique, and this technique basically what it does is that it uses this form of uh, uh, very strong uh, refractory stone that can actually go inside the oven, and it will withstand the excessive heat. And after the dyes has been prepared, the technician uses feldspathic porcelain that actually can be applied directly to the dye. As you can see, it's first it has to be wet a little bit, and then after the application of the process, this refractory dye will go inside the oven, and the porcelain will fuse together, and then another layer is applied, and then the whole process is repeated until the final results is achieved. Lastly, the CAD/CAM technology technique can be used in order to mill the final shape of the veneer directly from a ceramic ingot. This is later placed inside an oven in order for it to give the final shape and color, and the process of direct layering and internal characterization is done by the technician before it can be delivered to the doctor. This technique can actually help in having these veneers done chairside in the same day for the patient. In order for us to understand the process of how veneers are made clinically, you have to start by understanding the veneer preparation, the process for the shade selection, provisionalization, and the cementation. In terms of the preparation, in order for us to understand exactly how much we need to reduce from the tooth, there's a process called the mock-up. And usually what we do is that we start by doing diagnostic wax up on a cast. And after this diagnostic wax up is done in the lab, by using this silicon index, we can transfer the uh, the wax up to the patient's mouth using this index. And this would give us a final result similar to this, which is a rough representation of how the patient would look like after the veneers are done, and this process is shown, or this result will be shown to the patient to get his approval. If the patient approves this result, we'll start the preparation process. And usually we need to do the minimum preparation of about 0.3 millimeter at the cervical, as you can see, 0.5 around the middle, and about 0.5 at the um, uh, incisal 1/3. Um, Using these very specific wheel bears that doesn't drill more than the actual width here at the shank. So when we do the preparation, we usually do the preparation directly on the mock-up. And this process is done because we need to be as preservative as possible, because we understand that the final veneer form will be done according to the wax up. And of course, the wax up has some thickness to it, and we'll utilize that in the mock up while we do the preparation, because we want to be as conservative as possible. As you can see, for this case, for instance, after the mock up has been removed, we did just very, very minimum uh, preparation, because the veneers will be more uh, facial to the actual tooth structure, because we're adding more thickness to the teeth themselves. So this is considered as a very conservative form of preparation. Of course, we have to do some sort of shaping of the tooth by doing some uh, uh, shaping of the facial surface by creating the margins and doing some roundation for the tooth surface itself. And of course, we have to open the proximal contact slightly. This is the final smoothening of the preparation. And this is the final result. We have to take into consideration that everything needs to be rounded. All the areas need to be rounded. And not forgetting that we have enough thickness for the porcelain of about 1.5 to 2 millimeters at the incisal edge. In order for you to understand more about the preparation, you can scan the code, or you can use this YouTube link that would direct you to a video that would demonstrate the proper method of doing preparation. The step after that is to select the natural dye shade using this specific natural dye shade material or selection or guide made by Ivoclar. It's a worldwide known system, but there are multiple systems out there. So the name for that is called either the stump shade or the natural dye shade. They're both worldwide used terminologies. After we select the natural dye shade, which is the shade of the tooth itself, then we'll agree with the patient on the final shade. So if a patient comes with a very heavily stained tooth with an ND9, moving him to a very light shade would be quite difficult, which might require excessive reduction of the tooth, or we might need to change the material itself. When we get to the provisionalizations technique, we do a spot etch of about 1 millimeter spots of etchant, and then 1 dot of bonding is applied to the surface. Not too much of the bonding, because that's going to make the visc acrylic material stick to the tooth. So we need to be very careful not to dispense a lot. After that, we use the index that has been created from the diagnostic wax up in order to apply the material, and then we trim the excess directly in the patient's mouth. We have to be very careful not to damage the gingiva or damage the margin that we just created. And after that, we go to the final cementation result after the veneers have been prepared and returned back from the lab. And the cementation technique would require a thorough understanding of the process. First of all, we have to understand that the cementation sequence starts by the tooth itself. First of all, I have to make sure that the tooth is clean, and then we have to use the etchant on the tooth, and then the bonding agent on the tooth itself. On the veneer side, there's a surface treatment that is done specifically for the veneer. First of all, we have to apply hydrofluoric acid. This will cause micromechanical retentive pores that will later help in increasing the cementation strength between the veneer and the tooth structure. Then we'll use the primer on the veneer, keep it for about 1 minute. And then after that, we can use the resin cement applied directly to the veneer and then attached to the tooth structure. So this is about the middle point between the veneer and the tooth. The process here will start by an etch and then the bonding agent. And this area will start by having the hydrofluoric acid, the monobond, and the resin cement. The Ivoclean, this is by mistake here. Actually, the Ivoclean is used to clean the veneers when they come back from the lab. The Ivoclean is not used for the tooth. We'll correct that in the other slides. So in terms of the prognosis and long-term results, we have to understand that according to the literature, it has been shown that 2 major factors have resulted in veneer failures. First of all, unfavorable occlusion and the extensive dentine exposure. So having very conservative preparation done with favorable occlusion will increase the success rate for the uh, veneers. And also, we have to understand that um, uh, if there is more veneer, if there is more enamel that remains after the preparation, this will increase the success rate. So we need to be very careful with our preparation. We need to be very conservative with just enough reduction needed within enamel, um, and that will give us long-term success. So the survival rate was about 94%, according to Fradiani, for a duration of about 12 years. And they found that all of the veneers that were fractured, it was just because there's too much dentin exposed. And anything that is below 50% of enamel, all right, this would actually cause failure. We'll show one clinical case here, just kind of for you guys to understand. This patient came to the clinic with a diastema and a color of her teeth that is yellow and doesn't change with bleaching. And this tells you that this patient has very translucent enamel, and usually this is at the microscopic level where the or histologic level of enamel where she doesn't have enough hydroxyapatite that would give it very shining color. So her enamel is very translucent. That's why we're seeing denting, especially here underneath it. So what we did is that we started by a smile design, as you can see. And what we did is basically um, did a smile design for this patient. And this is how the patient, we agreed with her on the smile design that this is how she's going to look like once we're done with her case. So first of all, we can see that her teeth are small, so we decided to go for surgical crown lengthening. So we did the smile design. Based on that, we did the mock-up and a 3D printed model. Since this case we did it digitally, not the conventional way, we went in and had a surgical guide to indicate exactly where the final crowns would look like, and that helped the periodontist to actually cut the gingiva or cut the gum at the proposed length for the gingiva. And this is how it actually looked like after 2 months of healing. We can appreciate that the teeth here looks longer than the anterior teeth here. After that, we went in and start the digital process of designing the preparation guides. In this case, we did not use a silicon index. We used a 3D printed preparation guide. And then we printed the model from the diagnostic wax up. As you can see, this is her teeth before, and this is her teeth after preparation, and this is her teeth with the final diagnostic wax up. We did the silicon index on that cast, and here, this is how she looks before, and this is during the preparation. You can appreciate that we did very minimum preparation here, and this is how we did after we use the silicon index to provisionalize this case. And this is how the patient looked before the crown lengthening, and this is how she looked after the crown lengthening, and this is the preparation stage. This is how we use the guide here, and this is at the provisionalization point, and we can appreciate how the retraction cord is applied in preparation for the impression. After we got the veneers back from the lab on the working cast, this is how the case looks after the delivery. And This is how we started the lower arch, and that's the final results. Wish you all the best, and thank you for listening.